talk about it on behalf. Because the cultural issue, I asked Dr. Hami for help to lead the discussion. Yeah, maybe the participants will feel more comfortable. Yeah, please, Dr. Hami.
Dr. Hamid, can you share with us?
Still muted, Dr. Doni.
Doctor.
Okay, sorry. Maybe Dr. Galuh can explain about the some experience about traveling. Okay, Dr. Galuh.
Yes, I'm here. Actually, I don't have. I have a little experience about traveling in patient, so maybe I can speak many things.
Okay, maybe another Dr. Christian, please. Dr. Christian.
Thank you.
Do you have any experience about traveling in epilepsy patient?
Thank you. My experience about the patient with the traveling, I advise to the patient that if you want to go to traveling, please you go. If you pressure and the traveling is, and don't forget to take the medicine. But the more important is there is someone harus mendampingi.
Ya.
Mute.
Mute. Your voice is Dr. Chris.
Oh, sorry. Yes, I think it's the traveling is okay.
Would you recommend your patients to go to London to study, or to go to Melbourne, or to Perth, or to go to Kuala Lumpur to study?
Yes, I think it's okay if the take the medicine and is aware about his condition.
5 minutes.
Okay. Can you tell me what time is up? Is it?
Not yet, Professor. We still have about 4 minutes.
Okay.
Thank you.
Okay. Yeah, Cristiano. So would you give them some advice other than medication? Would you say that they must share room or things like this rather than live on their own room?
Yeah. Yes, this is live in the own room.
Yeah. Or any okay. I think we better go on to the second case. Dr. Herliani, the second case is about upbringing. Herliani, your group, is there anybody, did you have time to discuss about upbringing?
Sorry, Prof, my group is only one person, so join to others group.
Okay, Dr. Fitri, your group 6, is there?
Yes, Prof. Tan. I would ask Dr. Iin. Dr. Iin, please.
Yes, doctor. About the second case, that the patient is having bad relationship with her sisters, and also having like discrimination from the family. So I think first of all, that a strategy that we have to tell the parents is that to encourage, not to underestimate the potential that she has for school or any achievement that she probably have. And then we have to educate that discrimination can cause the stress that can cause or precipitate the seizure. And then to distinguish her and with her sisters is actually not that good. So I think stigma is the biggest case in this second case. And also we have to promote about the epilepsy to community and people, to tell that epilepsy is not boundaries, or it's not barriers to the patient to have like good achievement in either school or any community. Thank you.
You don't think you sort of interpret the case as the parents discriminate against the patient. The parents probably say that I love this girl even more than the sister. You know, it's too much love rather than too little love. What do you think? So it's not a discrimination in that sense of, you know, look at one higher than the other, but, you know, he in fact loved the patient more than the normal sister. What do you think of that?
I think action is more valuable than words. So I think that the parents said that love is it's like complex, and then so that they avoid the person to go traveling and then to not do anything. I think that's kind of like implicitly like discrimination. So we have still to tell the parents it's not something like contraindication to the patient to have the similarity right as her sisters.
Okay. No, the point is whether the issue is really discrimination or the issue is to allow the, you know, the children who have epilepsy or who have asthma or who have something else to have more freedom.
Professor Tan,
Yes, I think
a few seconds to wrap up. Sorry.
I think it's allowed we have to tell the parents that it is allowed to allow her daughter to go even traveling, and then yeah, I think the same similarity with her normal sister.
Okay. So I think we can move on now. Thank you very much for sharing. Yeah.
Thank you very much, Prof.
Thank you very much for the participants and Professor Tan for the large group discussion. We shall continue on the didactic lecture.
So I'm going to talk about cultural issues and psychosocial management of epilepsy. Psychosocial effect of epilepsy is actually in the ILAE definition of epilepsy, showing that this is such an important aspect of epilepsy management. This is a study from our patient in Kuala Lumpur showing how what we do is we compare our patients with their siblings who grew up under the same social environment, showing that our patients with epilepsy have 13 times more likely to be unemployed, to be below poverty line, where they earn less than 250 US a month, not to get married, and not to receive higher education. And in terms of economic cost, it is well known that the psychosocial effect is actually 2-3 times higher than the direct medical cost of epilepsy. This is based on Indian study. So the social consequences of the epilepsy is actually higher than direct medical burden of epilepsy. And stigma is a good concept to understand why this comes about. Stigma is what the society think of epilepsy and how it affect and impact on people with epilepsy. So it's a negative perception of people around that epilepsy patients are different and they are prejudiced, and this brings about the consequence to the patients. So the attitude of people around that bring on the consequence to patients, and it could be divided into felt stigma, how the shame that epilepsy patient feel, or it could be actually acted out. And discrimination is unequal treatment due to this stigma. So stigma has effect on the self-esteem, on the sense of mastery, a greater sense of helplessness, higher rates of anxiety and depression, and reduce life satisfaction. Stigma is a universal phenomenon for epilepsy. It's not just in Asia, not just in Indonesia, but even in the European countries. And as I said just now, stigma has socio-economic consequences, as I mentioned to you about our study in Kuala Lumpur, how it affects work and education and the poverty line. To understand how stigma bring this about, let us look at the KAP studies of stigma. I quote here the old Indonesian studies of the school teachers in the survey of their attitude to people with epilepsy. As you can see, the teachers, half of them would send or their students who has an epileptic attack to the hospital. And another question is whether they would allow their children to play with people with epilepsy, and the 1/4 of the school teachers would not. As you can see, such an attitude would result in the students not being encouraged to go to school, and so it affects their education and their future employment. This is an old study showing that in the Chinese culture, the epilepsy is a family disgrace. So that's why they are typically kept at home and diagnosis kept secret. And this is a more benign view, but still negative, about the attitudes of and beliefs of patients and society about their concept of epilepsy, that the seizures are triggered by too much brain work. And people with epilepsy should be confined to doing simple, special, not strenuous type of work, not too tiring type of work, because that might trigger seizures. That explains why they underperform in work as well as in education. So how then should we educate the patients as well as the family about epilepsy? I think we should tell them when we see our patients, it's not just giving them drugs, but spend some time to explain to them that this is a brain disorder It's not madness, it's not possession, and it's not contagious. And it can be controlled by medications. You see, the Asians, the view of cause of epilepsy or concept of epilepsy is often syncretic. On the one hand, they say this is an electrical discharge. On the other hand, they believe that it is due to heatiness, due to weakness, and due to some food such as mutton and so on. So it's the view is syncretic. It's complex. This is the study in China and Vietnam is due to wind as well as biomedical cause. That explains why it is common for patients in the East to take traditional medicine as well as anti-epileptic drug. And the important thing is that it can be controlled by medication, and it is important to ensure that this sort of syncretic concept is a reason why patient is drop out from taking anti-seizure medication, as the case 1 that was discussed just now. And they can go to school, they can work, they can marry, and they can have children, and they can play sports. Of course, one has to be wise. There are certain types of work, such as those that involve height, driving lorries, that would be unsuitable. And selling fruits and work behind the desk would be suitable. And leisure activities, climbing trees and riding motorcycles, of course it won't be suitable. And playing football would be suitable, but swimming, one would need to be supervised. So it is also a good thing to tell the patient to inform their teachers or their friends or their fellow workers what to do just in case they have a seizure. When we look at people with epilepsy, it's interesting that, you know, we talk about how epilepsy will affect patients' education and work and so on, and yet a number of people who have seizures, they continue to perform in their work and have this great motivation. And this is one of the greatest novelists in history, a Russian, and he said that every 10 days he had a fit, and after that he's incapacitated for 3 days, where he cannot collect his thoughts. And yet this Dostoevsky wrote many great novels. So this is our study of our epilepsy patient, trying to investigate the factors that affect employability in people with epilepsy. And self-determined motivation, in fact, is a very important factor why some people continue to work despite having epilepsy. And the other thing is that we know that epilepsy, that onset of epilepsy in childhood is a risk factor for people to get employed. So the upbringing, this shows that how a person is brought up has an important impact on their ability to function despite the epilepsy. And I use one testimony of a patient who talked about his neighbor who has extremely shy, who had epilepsy, and who had difficulty relating to people, having a profound sense of being different, an air of shame. And Susan Usiskin attributed to the parents' inability to accept the child's condition, and as a result, it affects the way the patient cope with it. She compared herself. She has an epilepsy patient where her parents, despite her frequent epilepsy, allow her to live alone, and when she go to university, and this attitude, positive attitude, enable me to function as an independent young adult when I reached 19, because the parents would not allow me to hide behind my health problem. So in the upbringing of the children with epilepsy, we should spend time to talk to the parents how to teach their children to accept their illness, and their children epilepsy not to have self-pity, and then encourage the child to be independent, and do not allow epilepsy to be a reason for him to shirk his responsibility, and do not spoil the kid, and do not let your sense of shame to stop your epilepsy children to go out to socialize, so that it does not affect his self-esteem, and also to strengthen him against a false sense of guilt and shame. So, but it is stigma is because of the community, how they look at epilepsy. So to correct this, it is also important that we doctors walk out from our clinics and try to educate the public at large, the whole community. And that usually means forming some epilepsy association and be involved in public education in different ways, such as workshop or literature, or encourage them, and in fact organize sports and other social activities to change the public attitude to epilepsy. Thank you very much.
Thank you very much about the didactic lecture. Does Professor Tan or maybe Professor Ernie want to say something to wrap up this topic?
No, thank you.
That was very good, Chong Tin. The only thing I would just emphasize is that it's really important. I mean, we're learning a lot about how to diagnose and how to treat, but that's only part of the patient's problem, is having seizures. All of the other psychosocial consequences of having epilepsy are often a much bigger problem. So I think it's really important. Just because it's last doesn't mean it's not important.
Thank you.
Okay, before we have the session of cases from the audience, I think we have 3 questions from the audience. The first one is, if there is an epilepsy case that is nearly 2 years seizure-free, and somehow they forget to take the anti-epileptic drug, or maybe there was a precipitating factor and then the seizure occurred, do we need to continue again the medication for another 2 years?
the question is addressed to
the audience is not specifying any panelists to answer. So I think can be anyone who's willing to answer.
I think the speaker for this is I think Ernie, you spoke on this, difficult to treat. You want to address this?
Okay, so I think the question was that if somebody has had
I think he's
no
seizure-free
seizures for 2 years, and then they have a seizure because they forgot a dose of their medication. So do we have to treat them for another 2 years before we discuss coming off medication? I think the answer is yes, you do, because what this has told you is that the epilepsy is still there. So without the medication, the person would have seizures. So, and the idea of waiting 2 years is because if no seizures have occurred in 2 years, there is a reasonable chance that the epilepsy has gone away, has resolved. Well, this tells you the epilepsy has not resolved. So I think, yeah, you've got to start the clock, start the timer again. That's now others may disagree. So any other faculty members or anybody else from the audience would like to say something? Please do.
We wait even longer for the next one. 3 years, 4 years, 5 years.
Maybe I saw something recently. I can't remember where it was. That is what I would think is logical. And I saw something recently where they said that a previous unsuccessful attempt at stopping medication did not increase your risk of the seizures coming back if you stop medication a second time. I think it may have been in this study that John referenced. I can't, but it was pretty recently that and I'm sorry, I can't give you the reference. But it doesn't make sense. It should be to me. Yeah, I would agree. I think it should be. It should make you even more careful, but apparently that's not the case.
It also depends on the sort of lifestyle that person have and how risky is this. In Kuala Lumpur, if you have to drive 40 minutes or whatever, you know, that will make a lot of difference versus a housewife who doesn't need to go out. And the other thing is a dose of drug. I think whether the dose of drug can be kept in a level that is sort of no side effect and so on. I suppose all this is not just yes or no, that sort of thing. I would take it that way.
It's not only yes or no. The duration of seizure freedom is very important, but we all know that certain epilepsy syndromes should never come off, or almost never come off treatment. And so that the underlying etiology plays a big role. The one thing that's answered by a seizure having occurred is exactly what Ernie's mentioned. The patient says, am I seizure free because the medicine is doing such a good job? Or am I seizure free because I don't need the medicine anymore? If you stop the medicine and a seizure happens, this answers this question. The medicine is doing a very good job, and so you need to stay on the medicine. And I totally agree with Ernie and Ahmed on this point.
John and Ernie, how about the dosage after the seizure attack?
Well, the question here is that the patient has been 2 years, almost 2 years symptom-free on low dosage therapy, and this is symptom treatment, and it's a little bit like treating high blood pressure or asthma. If the low dosage is adequate to protect the person, increasing the dose doesn't make much sense to me. because lower dose, less side effects, less cost to the patient.
Yes, I agree with you. Maybe I will use the last dosage.
I mean, sometimes if you are taking people off medication after a long period without seizure freedom, and this is, you know, if you've had the discussion and decided that this is a good thing to do, then sometimes if a person, let's say they're on 800 milligrams of carbamazepine, you reduce to 600 for a few weeks, nothing happens. You reduce to 400 for a few weeks, and then they have a seizure. Then it may be reasonable to put them back to 600 and not 800. So maybe you don't have to go all the way back up. I don't think there's any data to support that, but it seems logical to me, and it seems to work. So sometimes, you know, sometimes people are on bigger doses than they need, and the only way you find out is when you're reducing it and they have a seizure.
Yeah, I fully agree with you. Yeah, so that's why I mentioned the last dosage.
Thank you, panelists, for your answers. The next question is there any place for EEG usage in chronic headache? Is there any seizure that can manifest as headache? And how about there is, I think the participant have a headache case that they found an epileptic discharge on EEG. Thank you.
John, this is your question, isn't it?
Yes.
Yeah.
well, firstly, if you said to me, do I think that EEG as a routine investigation has a role in the evaluation of headache? The answer is no, without any doubt. Now, we all know that people who have had a seizure, after a seizure, a focal onset seizure, may complain of severe headache. And we also know that, in other words, epileptic seizures can trigger not only headache, but specifically migraine headache. The reverse also applies. A proportion of people with migraine, the migraine can trigger a seizure. And so there is an interface between headache, particularly migraine, and epilepsy, and they can coexist. And then, of course, if there's a concern about symptoms having an epileptic origin, EEG may be helpful. However, for the people who are presenting with headache as their only symptom, EEG has a very, very low sensitivity for picking up anything of relevance. And I would be worried about, it's a little bit like doing scans and finding unexpected and irrelevant findings. We can create bigger problems than the person already has by doing such tests as a screening evaluation. So unless there's a history consistent with seizures before or after headache, I would not be doing an EEG.
Thank you very much, Professor John, for your answer. I think we should move to the next question. So I think there are two questions about this. And I think this is for Professor Tan. When is the ideal time that we can give permission for a patient to drive by him or herself? And can they ever get a driving license? Thank you.
I'm not that clear, Kenita. I wasn't quite clear. He's talking about driving license.
Yes, Professor. So when is the ideal time? Can we give permission for a patient to drive by him or herself, and can they ever get a driving license?
Yeah, I mean, driving license is a legal thing, and that depends on that depends on country. In I understand Dr. Kwan just said that in Taiwan it is 2 years seizure freedom. I think in UK now it's 1 year, and if it's a nocturnal seizure, it is, then it is okay. Even if you have seizure, if it's only happen in sleep. And I understand now in Japan, if you have a seizure, now they have changed back the law to you're not allowed to drive. And obviously, and also commercial vehicle, you're not allowed to drive even if it's seizure free for a long time. But on the other hand, I think in the States, there are some states like Kansas City, 3 months they're seizure free, you're allowed to drive. In Malaysia, the rule is, Sherini just told me that it's 2 years in Malaysia for KKM. So I usually look at the, for example, I think one need to be other than the government rule, the other issue is what do they mean by driving? Because like in Malaysia, you are a rubber tapper. You tap rubber, or you go and pluck the fruits from the oil palm, and they often use a motorcycle to go to these sort of to collect this, to travel, and that is in a lonely road. Nobody else will travel there, so they are not, the risk to themselves and to others is actually not high. So I would be more lax about allowing them to drive in that situation. And on the other hand, like a bicycle, there's no legal rules about bicycle. It's not licensed and so on in Malaysia, but I would not recommend my patient to go to ride bicycle in Kuala Lumpur, the big road. It's so dangerous. In the suburb, I suppose it is okay, where there's hardly any car on the road. So this sort of thing, there is a legal part of the question, but there's also the situation. I think one should consider what is the risk that we are talking about. I don't know whether others want to say anything about this.
Yeah, well, I mean, I can tell you what happens in Australia, and we've pretty much followed the European methodology, which is that and what their argument is that if you look at driving in the general community, there are a number of factors that increase somebody's risk of a crash. Like if you're very old, or if you're very young, or if you've been drinking alcohol, or if you're sleep deprived, all of these things increase your risk of a crash. Some of them increase it by as much as 7 times, some less than that. And these things are all risks that society accepts, that the community says it's okay. If you have this risk of a crash, you can still drive, even though it may be double the risk of a normal driver. And so the argument is, well, if you're letting these people drive, then you should let people with epilepsy drive if their risk is not too high. So if their risk is maybe the same as somebody who's had 2 drinks of alcohol, for example, or something like that. And then you can try and work out what the average risk of a non-epilepsy driver is. And you can say, okay, well, if we're going to allow double the risk, then we can allow somebody with double the risk from epilepsy to drive. Now, the problem with that, and you can then work back and you can come up with figures and translate them to to periods without seizures before you let them drive. And, you know, the Europeans have done that and we've followed it. And that's basically pretty much where this 12-month period comes from. But as Chong Tin points out, the problem is that the risk in an individual varies enormously. It varies. Some people will drive, you know, once a week, and then a commercial driver will drive for 8 hours every day for 6 days a week. It depends on the kind of vehicle that you're driving. And again, as Chong Tin said, it depends on where you are driving. So there's all of these factors that come in. It all becomes very arbitrary. And then you've got the law. You've got whether there's a law that needs to be followed. In many countries, and I'd be interested to hear what the situation is in Indonesia, but in many countries like China and India, if you have epilepsy, you can't drive at all, ever. You just don't drive. And the problem with that kind of system is that people don't follow the law because the law is too tough, it's too hard. And so then you have people driving who are not safe to drive. And so the result of that is that actually the situation becomes more dangerous instead of less dangerous. And so the idea, the best solution probably is to have some kind of compromise where you allow some people with epilepsy to drive and you try and identify those ones with a low risk, and those with a high risk are not allowed to drive. And you try and come up with some rules to do that. So what is the situation in Indonesia? We've got lots of Indonesians here.
Yeah, may I say something from Indonesia? I think Indonesia is semi because actually doctor not recommend someone with epilepsy and still uncontrolled the epilepsy, uncontrolled the seizure, so we don't allow them to drive, to take car and the others. But our government, I don't know, I think not a particular to see if the someone have epilepsy or not. If he finished about the exam for epilepsy, for the driving, so it's okay. But when someone have trouble in the traffic and then they have any semacam pengadilan, so maybe the driving the person who drive is okay not to have any force because he is on epilepsy. This is my answer. Maybe the other friends can give the other comment.
Thank you for all the panelists. I think there are very great answers, and I think we should wrap up the question and answer session and move on to the next schedule, which is cases from the audience. And this will be chaired by Dr. Herliani Kosama.
Thank you. So there are 6 cases from the audience, but I think the time is not enough for 6 cases. That's why I only choose maybe 3 or 4 cases to present. The first case is will be presented by Dr. Kenita, please.
Thank you, Dr. Herliani, for the chance to do the presentation. Let me introduce myself. I'm Kenny from Samratulangi University, Manado, and would like to give one case discussion for this ASEPA Manado Virtual Epilepsy Summer Course. So the case is a 21 years old male. He is a college student, and his first seizure happened immediately after traumatic head injury while doing an acrobatic scene. The semiology is the pre-ictal is nothing remarkable. And ictal, there's the video, and post-ictal, there is a post-ictal confusion for 30 minutes. And he can remember the event after 1 hour, and this is his first seizure. So this is the video. There is no history of past illness and no family history of epilepsy. His physical examination was unremarkable, and his EEG result and brain CT scan result were normal. And the discussion we would like to bring up today is, what do you think occurred first? Is it the seizure first and the head injury, or the head injury then the seizure? And what do you think about the suitable diagnosis in this patient? Do you think we need to start an anti-epileptic drug in this patient? Thank you.
Okay, thank you, Dr. Kenita. So the first question, maybe we want to hear from Prof. Raymond.
Hello, yeah. Actually, the video didn't play very well on my computer. It was very slow motion, but I understand the boy was jumped off the from the wall, or then he had jerking. Is that right?
Yeah. So actually, he want to do a TikTok, like a salto,
right,
and then before seizure.
Yeah, this is difficult because I know in Australia they have this Australian rules football where people get this concussive epileptic seizures, so that when you have a concussion, you can get a seizure straight away. I think this was shown in several videos. I can't remember whether it was John or Ernie, but I've seen this before. And it may be difficult to diagnose otherwise because the interictal EEG might be normal. So it's really from the story and from the video. Did the patient have any other phenomenon after the attack? Did he have drowsiness or sleep or headache or incontinence of urine or tongue biting?
Concussion for 30 minutes, and he can recall only after 1 hour.
I see. But there was no urinary incontinence or tongue biting?
No.
Right. So this was the only attack?
Yeah.
Right. But I think it could be it could be this concussive, convulsive seizures. You know? I think, I don't know, just my impression, because the video didn't play very well here. So if he was truly unconscious for 30 minutes and just laying still, right? That means a post-ictal sleep or coma, then one would think that this would be a real epileptic seizure. But I think it's a concussion causing those convulsive movements. I don't know what the Australians will think about this, but that's my opinion.
Thank you, Prof. Raymond. Anything to add? Maybe Prof. Ernie or Prof. John?
I can only agree with Raymond. This is a concussive convulsion.
And that when they did this study in Melbourne, what they did is looked at, somebody did a PhD, I think, looking at videos of Australian rules football matches and watching videos of people having head injuries and then having what looks like a seizure. And they followed them, they investigated them with EEGs and followed them. I don't know how long they followed them for, but their conclusion was that this is not epilepsy, that it may be, it's a bit like convulsive syncope. It's not the same mechanism, but that it's not actually an epileptic seizure, even though the motor activity looks like a seizure, and it doesn't mean that they're at risk of having further seizures. That was their conclusion.
Okay.
Yes, and so the patient does not need anti-epileptic therapy. The prognosis is excellent. And Australian rules football is a very violent game. And last night, Brisbane were playing Collingwood, and there was a concussive convulsion during that match last night when I was watching with Sandy, my wife. So it's a common problem.
Yeah, I used to support Collingwood.
But I think the pathological mechanism will be like a seizure here, isn't it? I mean, so long that I think it lasted a few minutes, and
yes,
after that there is a, I would think it's like a seizure. Although maybe it's better to treat it like a provoke seizure, or
absolutely.
Treat it as provoke is better word, I think, and then tell him next time don't go and do this acrobatic game. You do something else, fishing or play Australian football, something like this, but don't do that. But don't label him as epileptic in that sense that he doesn't really fulfill the definition of epilepsy. But that attack, the mechanism is I don't think it's brainstem. It is from the brain.
You're absolutely right. And whilst there is some debate, you can have a concussive episode that might look like syncope. I agree with this. This is a trauma-provoked seizure, and in a way, almost like electroconvulsive therapy. He's had a traumatic induced convulsion, which is epileptic.
So I don't know if boxers get this.
I don't know.
Well, the short answer is boxers. If somebody KOs them and knocks out onto the ground, and they can have a convulsion, but most of the time, no. Mostly it's a concussion, and in other words, it isn't an epileptic seizure. It's an acute loss of consciousness related to the brain trauma.
John, can I just ask that when they have this concussion, when they hit each other, are they in the air or on the ground mainly? I was just thinking whether
the match last night, what happened is somebody was running for the ball, somebody's head was in the way, and the person's hip hit their head, and over they went, crashed to the ground, had some shaking movements,
right.
Did not wake up. The stretcher came on, was 5-10 minutes still on stretcher off the field. And so then we have a problem where we're trying to discriminate between a concussion, a seizure, or both, but it's a bundle together.
I'm just trying to draw a similarity here. This guy in the video here was jumping in the air and then, fell down. And in Australian rules football, it's often, reaching for the ball in the air.
Yeah.
Whether that has anything to do with it, rather than boxing. Boxing is always on the ground. I don't know.
Yeah, Raymond, I agree with you. I will keep my eyes on this patient very closely for at least 3 months. Especially this CT was done maybe earlier, maybe at the same day, maybe only several hours later. You will not know whether this case will have delayed intracerebral hemorrhage at the end of 1 week, or you will have, or the patient will have brain edema 2 to 3 days later, or subdural hematoma, anything, because of the somewhat increased legal issues. I think I will put my eyes on this case and watch very closely.
Okay, thank you for all the opinion. So I think we conclude this case is non-epilepsy. We move to next case. Will be presenting by Dr. Anton.
Okay, thank you for the opportunity, Dr. Herliani, and good afternoon. This will be my case presentation for this summer school. Next slide, please. Well, this will be part of my presentation, and we'll begin from the clinical data. Slide, please. This is a 20-year-old male admitted to the emergency department with seizure and unconsciousness since a day before admission. And the seizure was told focal to bilateral, begin from the right extremities and right facial muscles, then spread to the whole body. The patient was unconscious from the first seizure and stayed on that state between seizures, which had occurred 3 times. And there was no history of seizure before, and patient was a healthy, hardworking pre-graduate student who worked part-time in a factory. Next slide. From the physical examination, we found a soporous, normal-weighted man with normal vital signs and no fever. The neurological examination revealed neck stiffness and extensor plantar reflex of both legs without any sign of extremity weakness. And brain CT scan without contrast showed no remarkable finding. That examination found only mild leukocytosis with neutrophilia and lymphocytopenia. The cerebral spinal fluid analysis found increased amount of cells, predominantly mononuclear cells and hyperglycorrhea. Protein and chlorida were normal. Next slide, please. So then the patient was treated on status epilepticus protocol, and after fail of 2 times, and then the phenytoin was given in loading dose. The jerking movement stopped, but the patient remained delirious. Empirical antibacterial and antiviral drugs were given intravenously, and then the EEG recording later show a general slow wave-based EEG with periodic epileptiform discharges on left temporal area, which I will show you in the next slide, and a diagnosis of non-convulsive status epilepticus on suspected meningoencephalitis was made. Patient was placed back on status epilepticus protocol, and valproic acid was loaded on. And then the motoric focal convulsion on right side of the face and body began to occur again and remained happening despite administration of 2 more drugs, which are levetiracetam and topiramate in loading and maintenance doses. And we also gave midazolam and propofol. The body temperature kept rising, and the patient got complication of aspiration pneumonia also and became comatose. And eventually, patient died with focal subtle focal convulsion persisting until the end of life. And I will show you the EEG for this patient. So there are prominence of epilepsy from discharges in F7 and T3 in left anterior temporal area. Next slide, please. This is the double banana montage for the recording. You can see F7 is the prominent epilepsy from this chart there. Next slide, please. This is the other epoch showing the most of the same things with the last epoch, general slow wave EEG and with epilepsy from discharge in anterior temporal area. Okay, next.
Sorry, this EEG is a biplat or plat? I mean, because what is a montage? Is it a biplat or is it a plat? Is it only on the left side or is both sides?
I think it's both sides.
Both sides, is it?
I say
It's
it's
generous,
average montage. The upper half is the left hemisphere and the lower half represented the right hemisphere, is that right?
No, it's a double banana.
No, average here.
Yeah, but it's average double banana.
Yes, average.
Left, right, left, right. Left, right, right, left.
No, it's left, left, right, right.
Sorry.
This shows that you can't read EEG on a small screen.
There is an AP montage. I think if you go before that, I think there was an AP montage slide before that.
Yeah, AP bipolar montage will be better instead of average. Common average, you would have some kind of combination.
Yeah.
Okay, you better go on and see.
Yeah. So there is a short video of the subtle convulsion of this patient. Okay. I think that will be my presentation. Thank you very much. I hope for comments from and what should we discuss here is what could be the factors that cause a refractory status epilepticus and how to treat such kind of refractory status epilepticus. Thank you very much.
Thank you. Maybe Prof. Kwan will answer this question.
Yeah, unfortunately, the case expired. It's not uncommon. Yeah. Okay. For this case, I think if the epileptic form discharges has somewhat localized or lateralized to the left temporal region, can this be a case of herpes encephalitis? Do you check the herpes titers? and maybe the antiviral, the dosage of antiviral agents are not enough. I don't know, maybe enough already. And from the EEG and the clinical manifestation, I will not put this case to be a non-convulsive status epilepticus. I would like to put him as a case of subtle status epilepticus. Yeah, so the prognosis, that can explain why the prognosis is so bad. And how to treat such kind of refractory status, I think it's quite difficult. You can follow the flow chart I show you this morning, but I think you have done very well. You have tried levetiracetam and topiramate, dilantin at first, of course. With lorazepam, I believe you have used all the medication, even the propofol. Yeah. So the cause for the death of the status, I think maybe the duration is the key factor. I forget how you spend how many how much time to control his general convulsion. But even you control the general convulsion, the EEG still shows periodic discharges. That is compatible with the diagnosis of a subtle status epilepticus. So the prognosis is still very poor. So that's, I think, can explain why the patient finally still expire. Of course, the pneumonia, aspiration pneumonia also play a role in his death.
Well, can I make a comment here? I think the patient obviously has an infection of the brain. And so the issue is the brain, that eventually what kills the patient, is it the seizure or is it meningoencephalitis or is it both? I have a feeling that it is probably more encephalitis that actually is the main thing rather than the seizure, because I see that one of the EEG with the AP montage, bipolar montage, it looked to me like a biplex. So that would suggest that the brain, both sides of the brain are sick, you know. And the only thing worries me is that, you see the cells, there are 40 cells, but the white count is 14,600. And that usually is seen in bacterial meningitis rather than viral meningitis. It is a pity if actually the patients die from bacterial meningitis, something treatable. That's the sort of, but you know, I believe from what you told us a story, and it is, although you tell the story as if this happened very acutely, but I wonder whether he actually already have 2-3 days symptoms, you know, and it's not such an acute event that he just have a seizure out from nowhere, you know. That's my comment.
Can I just comment one thing that if we are, I mean, the first thing that we think about is sort of infective cause, so bacterial or viral. It's just that I'm not too sure what antibiotics was used, but the usual first line treatment that we probably would think of is the ceftriaxone and the acyclovir. But not to forget that I sort of had recently a listeria meningitis, and it is important when they come in at the beginning to give them some steroid as well, including the antibiotic, antiviral, and also ampicillin while waiting for the listeria to come back, because they can be really, really sick with listeria meningitis. And the CSF counts can be a bit confusing because they can be predominantly lymphocytes, they can be predominantly neutrophils. Yeah, just a thought.
just another thought or comment. This is somebody who doesn't have epilepsy. This is an acute presentation, and so his status epilepticus is just a symptom. It's not the problem, just as Chong Tin and Shirini have said. And the treatment of the underlying cause is going to determine whether he lives or dies, whatever we do with the anti-epileptic medicine. Now, whether it's infective or inflammatory, we don't know, but we know that the brain is irritated. The only other comment I'd make with respect to the serial use of anti-epileptic drugs is that one step after the other, you need to make sure that you've used each drug to the maximal effect. For example, in people who are severely ill like this, I don't know how easy it is to weigh them, but I find it quite difficult in the emergency centre. So for phenytoin loading, I would guess the weight and give a generous amount, 20 milligram a kilogram minimum. And if ongoing seizures are occurring, an additional 5 to 10 milligram a kilogram. The idea, by the way, thinking of phenytoin as the only drug, a therapeutic level is not sufficient in status epilepticus. I'm aiming for high levels. I'm not worried about nystagmus and ataxia. I'm worried about undertreating the patient. The same goes for valproate, 30 milligram a kilogram, levetiracetam, 50, 60 milligram a kilogram. This is not the time to be thinking of small doses as you escalate treatment up quickly and then anesthetic. But the cause will drive prognosis, not just the treatment of the symptom.
Okay, thank you. So the conclusion of this case is...
So there's no postmortem?
No, Professor, we didn't perform any postmortem examination for this patient.
Postmortem examination in Indonesia is uncommon, Prof. We're not doing it.
Even in Manado?
Yeah.
So maybe we should spend some time to look at this case again. How about the dosage of the anti-epileptic drugs that you use? What about the serum level of phenytoin? To my experience, yeah, I fully agree with John. The dosage should be very, very high. Yeah, the serum level of phenytoin, if you want to control a status epilepticus user, it must reach 30 microgram per milliliter, 30 microgram per milliliter. That is much higher than the usual therapeutic range. So how about the dosage and also the serum level of valproic acid in this case?
Yeah, so we didn't perform the plasma level of phenytoin also. We didn't check it also. Yes. Yeah.
Okay. Anything else to add, Prof?
Is MRI available in Manado?
Actually, MRI was available in my place, but we didn't perform it because there is also a lack of there was also economical problem of the. So we were suggesting PCR of the HSV and PCR of CMV and also COVID-19 at that time, but there was also an economical problem for that from the family.
Understand. Thank you.
Thank you, Prof.
Thanks. Thank you. So for this case, the conclusion is this is the meningoencephalitis, and the status epilepticus is the symptoms of the meningoencephalitis. And we need to treat the underlying disease for this case also. Thank you. We go to the next case. The next case will be presenting by Dr. Distia from Gadjah Mada University, Yogyakarta. Dr. Distia, time is yours.
Thank you, Dr. Heliane Kosama, and all of the professor and doctor here. Now I'm as the representative from the Universitas Gadjah Mada. I would like to present our case in our hospital. Next. 23 years old pregnant woman with a gestational age 24 weeks referred to our hospital with the complaints impaired awareness, focal seizures, and automatism since 2 years ago that occurred more frequently since 1 week ago. The frequency of the seizure was once until 3 times per week with a duration less than 1 minute. The pre-ictal condition was headache, restlessness, and panic, and also the post-ictal condition was confused for 1 minute. The history of the absent seizures happened when the patient 10 years old with the unknown therapy, but the development and the growth still good. Physical examination was normal. This is the video of the ictal of this patient we got from the family. In this video, I see that the patient got the automatism and also blank stare. And also on the next video, we found the right hand dystonic.
Recording stopped.
Okay, in this patient, this is the treatment history since 2019. The patient got the motor seizure with automatism, and then from the previous neurologist, she got the Depakot 500 milligrams daily, phenytoin 100 milligrams twice daily, and folic acid 1 milligrams twice daily. And then on 2020. The patient planned for married and pregnant, so she consulted to the neurologist, and the neurologist decided to stop the Depakot and continue the phenytoin and folic acid. On September, the patient became pregnant, and she referred to our hospital with the pregnant condition, but the seizure still persisted with the same type and the frequency. So our neurologist decided to add the Lamictal or lamotrigine with the low dose in the early administration, and also monitor the seizure. But until now, the seizure still occurs and occurred more frequently until 3 times per week with the same type and duration. So we decided to increase the Lamictal until now. The dose was the 50 milligrams morning and 75 milligrams in the evening. Okay, next. This is the EEG of this patient. We found the sharp and wave discharge on the temporal on the left temporal, and the focal slowing on the left temporal that happen very frequent. Okay, next. Next. Okay, next. And we performed the MRI cerebral neural contrast, but we found the normal condition from the MRI. So the reason for this patient was the semiology was right hand dystonic, automatism, blank stare. The EEG finding was background slowing on the left with very frequent focal epileptiform discharge on the temporal region, and the MRI was normal. So the problem, next. The problem for this case, the first is what is the final diagnosis for this patient? And the second is how is the best therapy in this patient, especially in the second trimester pregnancy condition? Which drug should we decide to increase first, the phenytoin or the lamotrigine, or we have to do another step? Thank you.
Thank you. Thank you. So for this case, we have two problems, the diagnosis and the therapy. For diagnosis, maybe Prof. Raymond.
Yeah, thank you. Can you just look at the MRI again? I thought the left hippocampus was smaller. Just that, just the coronal view. Unless you have a flare, I can't see a signal change, but it looks smaller, and the spikes are from the left. If you can see the hippocampus there, the whole brain looks a bit, for this young lady, it's a bit atrophied to me. You know, you can see a lot of CSF and widening of the sulci at the top of the head near the vertex. I don't know what the other thing, but I thought the hippocampus on the left, which would fit the right, this hand becoming dystonic in this girl. So I would have thought that this is hippocampal sclerosis, or, you know, but I can't tell you about the signal change because it's only one slice. And the flare, did you do flare images? Did you do that sequence?
Yes, we did the sequence of the flare, but I'm sorry, we didn't present in this slide, Prof.
Right. Okay. But anyway, I thought, Dr. Herliani, that this patient, you know, with a typical arm being dystonic and so on, and the discharges from the EEG that she has temporal lobe epilepsy due to hippocampal sclerosis. I don't know. That's my opinion. Again.
Thank you, Prof.
Prof, if we see the history taking, this patient also has a history of absence seizure. So is there any correlation between the absence and the temporal lobe?
Absence. Yeah. Sorry.
Okay.
Go on, Ernie.
Oh, sorry, I wasn't saying anything. What did you ask me?
No, I thought you were going to
I thought it's Kwan, Professor.
Oh, Dr. Kwan. Okay,
sorry, Raymond, it's me.
Yeah, sure, go on.
Yeah, okay. Sorry to interrupt you. I don't think this is a case of absence seizure. Usually we mistaken the absence, this term, on the patient of temporal lobe seizures. I think if you want to use absence-like episode, I would suggest you use dialectic seizure. Maybe this case has a dialectic attack. Dialectic can be a temporal lobe seizure, can be absence. But I think this is a case of a pure mesial temporal lobe seizure. And from the EEG, the background is also slow, diffusely slow, even in delta range over the left hemisphere, especially the temporal region. I think, Raymond, you are correct. I think, to my opinion, to my experience, this might be a case of mesial temporal sclerosis because the continuous slowing at delta range suggesting the focal structure lesion. This type of seizures is very commonly seen in mesial temporal lobe sclerosis. May I ask you, do you have a ear reference montage? Did you see all positive spikes over the left hemisphere? Have you? Yeah.
Thank you, Prof. Yes, I have read the
A1, A2.
Yes, A1, A2, but I didn't present it in this slide. I'm sorry.
Did you see positive spikes at this time, at the same time? All these negative spikes over the left anterior and mid-temporal region, right? Equipotential at left anterior and middle temporal regions. But if you look at this EEG from A1, A2 year reference montage, these spikes will contaminate A1 year electrode. Then in A1, A2 year reference montage, you will see all these spikes looks like a positive spikes over the whole left hemisphere. So this is an indirect evidence to support the diagnosis of a mesial temporal lobe seizure disorder.
But just to expand though, we know that this young girl has focal epilepsy. The videos show this, and the dystonic posturing of her right arm points to a left-sided focus, probably temporal. As Shang Yang mentioned, terminology, and Ernie has been on the terminology committee. It doesn't matter whether we call these focal unaware seizures or if we call them complex partial seizures or dialectic seizures. Our patients are going to tell us, I've had an absent seizure, I've had a blank spell, and we all acknowledge in general usage, even amongst our medical colleagues, that absence means a blank spell, and that may be generalized absence seizure or a focal unaware seizure. And so there is no incompatibility in the history. She's had at least a many-year history of focal epilepsy, and now it's getting worse because she's pregnant for a number of reasons that I'm sure we'll discuss.
Well, the other reason she may be getting worse is I think her phenytoin was cut in half, wasn't it? The dose was halved and valproate was stopped before she became pregnant. The phenytoin has now come back up, but she's not back on valproate. Now, valproate is not the drug of first choice in focal epilepsy, but it can be effective in focal epilepsy. And the fact that she's come off it, as well as having the phenytoin reduced, may be the reason why she got worse. And then also the and lamotrigine levels fall during pregnancy, and that dose, she's only on 125 milligrams per day. That's a very small dose for someone who is pregnant. So I think looks to me like there's a lot of room to push the doses of her drugs. It may not work, but it might.
And just to expand on that, lamotrigine clearance increases by about 90% in the third trimester. And if you look at patients even well controlled on lamotrigine, unlike this girl, seizures increase in about 40% because of this increased metabolism. So there's several things happening at once for this poor girl: change of medicine to an unknown medicine and increasing metabolism caused by her pregnancy.
Thank you. How about the interaction between the lamotrigine and phenytoin?
I think the phenytoin is metabolized in the liver. Lamotrigine metabolism in the liver is very little. I think it's about 20-30%. Personally, I would just push up the dose of phenytoin to 300. He was in 100 and then increased to 200. And the lamotrigine is subtherapeutic dose. And I presume she's not a big size sort of Javanese woman. So 300 until the she got control or something like this, lamotrigine is not likely to do anything.
The lamotrigine dose is too low, isn't it, Prof?
Yeah, it's too low. I mean, although, the textbook talk about at least 200 milligram. Yours is 125. So although this is probably based on the Caucasian data, and you can get some patients that respond to a lower dose, but yours is really low, and some more she's pregnant. So I would immediately increase the phenytoin to a more usual sort of effective dose. I don't think, Sarini, I think you prepared this lecture. I don't think this phenytoin, of course, there is such thing called phenytoin syndrome and this sort of thing, but she's already on the second trimester. I don't think there's anything on phenytoin to suggest that there is such a thing as phenytoin producing a low IQ, like what they talk about in sodium valproate. Is there?
No, you're right, Prof. Now she's already 24 weeks. The only thing is it can cause cardiac defects as well. I guess if I probably would go with increasing the lamotrigine. If she can tolerate, do it a bit faster for her. Like you said, Prof, they can go up to about 300 a day if they really need to. And maybe later on.
I thought it's much higher than that. But it wouldn't, money is an issue. Is that money is not an issue? Lamotrigine is a more expensive drug.
Yeah, so that's my next question is do they have to pay for their lamotrigine, because that does make a difference in our patients. Otherwise, she's already been taking phenytoin, just sort of like Prof Tan say, push up the phenytoin, advise her or counsel her on the potential side effects. But I would still push for the lamotrigine first. Yeah.
Prof Lim, do you want to say something? I see you are unmute.
Sorry. Okay. Thank you. Maybe just to add on a few as answering Prof Tan questions, lamotrigine can go up much higher dose. Without concomitant sodium valproate, lamotrigine can go up to 300 milligram BD. And just now, Haliani asked a question about phenytoin. I have a quick check because lamotrigine metabolized in the liver as well, and the level can be the clearance can be reduced by valproate, partly because of enzyme inhibitions, and can be affected by phenytoin and carbamazepine because of an enzyme-inducing effect. And the level of lamotrigine will drop as well, as John Dan mentions, that especially during the second and third trimester due to estrogen effect. So technically, the lamotrigine dose is not adequate. But urgently, if you really think about teratogenicity, which has already passed is already in 24 weeks, there are either way maybe consider, either increase phenytoin now or increase lamotrigine can be considered. But for the next pregnancy, we probably want to try to avoid phenytoin. But I on my mind is because I was thinking for the trainee's sake, and we go through a quick summary of what we have learned in this course. So the first question is it an epilepsy? Then your answer is yes. Then the second question is what is the seizure types? Then you say, this is focal epilepsy, focal seizure. And then when you ask where is the seizure is coming from, then you say it's likely temporal lobe, likely from the left side because of right dystonia and right EEG temporal discharges. And possibly there are some MRI changes, which is suspicious, but you want to go through a little bit more detail. And then the fourth question is it medial or lateral temporal, as Dr. Ari's lectures mentioned? Then you want to think whether there is aura to suggest more of medial temporal or more lateral temporal. And then then you talk about seizure control, the dose and compliance and pregnancy and so on. So in fact, this is a good case. Actually, we have covered quite almost most of the lectures that we have learned in this course. Thank you.
Thank you. Okay, so I think we need to move to the next case. We still have one case from University of Pajajaran, will be presenting by Dr. Seni.
Recording in progress.
Thank you, Dr. Heliani and all tutor. I will share our patient case in Bandung. Next slide, please. This is 24-year-old male with episodic seizure with semiology, head and eye turn to the left, followed by tonic-clonic seizure with impaired awareness. The frequency 1 to 2 times per week. And after seizure, patient looks confused for about 1 minute. Seizure duration approximately 2 to 3 minutes. Some of the seizure was preceded by an aura. Patient heard ringing sound and lips making, and the seizure most frequent during sleep. In past history, he's had 4 seizures at 3-year-old, reset by febrile and diagnosed epilepsy at 8-year-old, and he's had a normal birth history, growth and development. Next slide. In physical examination within normal limits, and the result of laboratory examination within normal limit except hemoglobin and platelets. Next. This is a head MRI with contrast in April 2017 within normal limit. Next slide. And the EEG results, we found sharp waves and slow waves over the left temporal region and bilateral frontal slowing. Next slide. Next slide. So this patient we diagnosed as temporal lobe epilepsy and get therapy carbamazepine 2 times per day, and the seizure still common 1 to 2 times a month after getting AED. Next slide. In April 2018, the patient was hospitalized due to status epilepticus triggered by pulmonary infection, received a leading dose of intravenous phenytoin, and then continue with oral AED maintenance with phenytoin 100 milligrams 3 times a day. And the patient still had seizures 3 times per month, and despite compliant oral AED. In November 2019, the patient still had a seizure 5 times a month, and we decided to examination the level of phenytoin in the blood, and the result is 22.73 milligram per liter, and the phenytoin reached the therapeutic level, but this patient still having a seizure. So this patient fall into condition of phenytoin drug resistant, and we are tapering down the phenytoin and switch into carbamazepine. Next slide. In March 2019 until now, the phenytoin stopped, and then up titration carbamazepine until 3 times per day, and the patient has no seizure until now. Next slide. My question, the first, why does this patient respond to carbamazepine but not to phenytoin? As we know, both of these drugs have the same mechanism. And the second, when can we switch to carbamazepine after administration of intravenous phenytoin loading? Thank you, Doctor.
Thank you, Dr. Seni. So the first question, I think is in Dr. Suryani topic, the initial treatment for epilepsy. Dr. Suryani, what do you think?
Yeah, this patient was responding to carbamazepine, but not to phenytoin. Actually, in my opinion, even if the patient have status and was given phenytoin IV, I think the maintenance of carbamazepine can still be continue as the maintenance dose. So no need to change to phenytoin orally. And in fact, the phenytoin actually have more action than the carbamazepine. Carbamazepine only work in one action as sodium channel, but phenytoin in some other channels. So I'm not quite understand why the patient can respond to carbamazepine but not to phenytoin.
Oh, now could I say something, Suryani?
Yes, please,
Because
Jonathan.
this is something that I feel very strongly about. The idea that we fully understand the mechanism of action of anti-epileptic drugs is completely incorrect. For example, let me take sodium channel blockers. Sodium channel blockers like carbamazepine may aggravate absence, as we know, but this is not because of the sodium channel blocking effect of carbamazepine. It is because carbamazepine is GABAergic. It enhances GABA in the thalamus, and this has been shown in experimental studies. Lamotrigine is a sodium channel blocker. It is very good for absence. Lacosamide is a sodium channel blocker. It may be effective. Zonisamide, topiramate, and valproate all have sodium channel blocking capabilities. So the idea that we are dealing with the same class of drugs is just not true. And as Ernie said earlier, patients can respond to carbamazepine or phenytoin, and the reason is because they are not the same drug. It is the same problem with calcium channel blockade. Lamotrigine sometimes is thought of as a calcium channel blocker, but so is zonisamide, valproate, levetiracetam, part of their action. So all of our drugs are dirty polytherapy. And the idea that a mechanism of action is going to guide our treatment is a mistake. What really guides our treatment is what does this drug work for this seizure type? And a good example is sodium channel blocker. Lamotrigine is a sodium channel blocker. Does it work for absence? Yes. Do we use it for absence? Absolutely. Similarly, levetiracetam, does it work sometimes for generalized seizures? Yes. Does it matter that it blocks, it's a synaptic vesicle protein effect? No, it's actually its clinical usefulness. And so I think we disadvantage patients by being guided by mechanism of action. We lose things. Lacosamide, sodium channel blocker, but also is carbonic anhydrase inhibitor. So is acetazolamide, so is topiramate. So all of our drugs are dirty. Valproate has many mechanisms of action that we do not understand. So I please say, do not think of mechanism of action when it comes to choosing drug. Think, can this drug help this seizure type?
Okay, thank you, Jonathan. Maybe others can help with this case.
I think the question is on the switching, especially the second questions. In the past, when we give IV phenytoin as a treatment in the emergency, then there is a tendency to switch to oral phenytoin. And the question is asking whether we can switch to carbamazepine after using IV phenytoin. Oh, Heliani, I think this is a question, isn't it?
Yeah.
Yeah, the second question.
So
well, just quickly, I can't see why not. I don't see why not. But anyway,
happens all the time in emergency where patient was given IV phenytoin, or probably the neurosurgeon will start IV phenytoin. and then the patient comes to you, and then the minute you saw that, you just quickly switch to whatever anti-epileptic you prefer. That's what I've been doing anyway.
Okay.
I think the consideration of oral drug is long term. The consideration of IV drug in the stages is short term. So the consideration is a bit different, isn't it? So, and you know that some drugs work intravenously, but doesn't work orally. I don't know all the magic behind it. The obvious one is Valium. Valium work is a wonderful drug intravenously, but orally it doesn't work. Maybe the absorption is too erratic, you know, so it doesn't quite correspond really. So I don't know whether that answers the question.
Okay, maybe Prof. Ernie want to add something, Prof?
Sorry, I think we. Sorry, do I want to say anything more? Is that what you asked?
Yeah, yeah.
Yeah, I don't think so. I think everybody's made very good points. Yeah.
So can I ask Prof. John then? John, so if we are not realized to the mechanism of action of the AED, how we can choose the first line drug for each seizure type?
You're muted, John. You're muted.
The decisions are guided by the seizure type, avoiding side effects, and avoiding side effects is very important. And this means tailoring your choice to the individual's age and sex and other medicines and other comorbidities. And so these will guide us rather than mechanism of action. And a good example here is carbamazepine, a good drug for temporal lobe epilepsy? We all agree it is. However, if the patient says, I don't want to take medicines more than once a day, maybe carbamazepine once a day might work. We give it a try, even though we normally give twice a day. Or maybe she says, can I have that phenytoin? Because I can only take once at night. And so we will be guided by the individual circumstances as well as the seizure type, rather than mechanism of action.
Yeah, I think mechanism of action is something very useful for drug companies to try to, market their drug as having some advantage over competitors. But yeah, in practice, I agree entirely with what John has said.
Okay, thank you. Because the time is up, we need to do post-test. I think we need to wrap up. My apologies to Dr. David and Dr. Iin. Because of the limitation of time, we cannot present your cases. The next is post-test. Kenita?
Doctor, thank you very much to the Nikosama and all the panelists, which have been giving very great opinions on the cases. We will start our post-test right now. And if the participants can choose the question, and maybe we will discuss each question based on the topic shared by the panelists. So we will start now. Thank you. This is the first question. Please do not forget to press submit. Okay, most people answered the third option. I think Prof. Raymond can explain about this question.
Yep, that's right. Although there's some people who answered other things, urinary incontinence, of course, can be seen in syncope. So that's not right. Even my patient had with pseudo seizures had urinary incontinence as well. Biting of the tongue, of course, not. It's quite common in syncope. And you saw the video that I showed you in the experiment with the German medical students. Jerking of the arms and legs can be seen. And of course, stiffening of the body as well. Confusion would be unusual for syncope. This should be very brief, if at all. But if it's prolonged and it's quite obvious, it is probably not syncope. It's going to be an epileptic seizure if it fulfills other criteria. So I think that was quite straightforward, and I think the performance is okay. More than 50% got that right. Okay.
Okay, thank you very much, Prof. Raymond. I think we shall continue to the next question. Here is the next question. Okay, thank you to all participants. I think Dr. Aris can explain about this question to the participant.
Okay, thank you very much. Yes, for this question is which of the following features such as idiopathic or genetic generalized? So for the first answer is first is age 40 years. I think we know that in the 40 years is many factors affect the someone. So it's probably is not good answer for the idiopathic. History of head injury and loss of consciousness is the same. It's not good for the genetic. Hemiparesis, yeah, hemiparesis actually is represent there is any manifestation of lesion in the other contralateral of the brain. And then jerks on the hands during the first hour after waking in the morning. So it could be yes here because jerks in the when 1 or 2 hours after a week, this is represent about generalized tonic-clonic seizure alone. And then last is EEG showing spikes in the post-temporal region. Probably we know that is the post-temporal right and left, but it is bilateral but not generalized. Yeah, could be temporal left and then followed by right temporal. So it's not generalized. It is not remind the for the idiopathic. So the answer is in the fourth, and we see this 50 no 52% is good. Thank you.
Thank you very much, Dr. Aris. I think we should continue to the next question, which is the third question, which is shown now on the screen. Please do not forget to press submit. Thank you. I think this question compromises the third topic by Dr. Suryani.
Okay, thank you. So I think 95% of the answer is correct. So the side effect of carbapenem mostly is weight gain and tremor. And carbamazepine is not suitable for the IgE. And skin rash usually due to carbamazepine and phenytoin. And carbamazepine should be started at a lower dosage, 100 milligram once or twice daily. And then usually carbamazepine can be taken 3 times daily, except in chrono. In chrono, we can use twice daily. Okay, thank you. Good.
Thank you very much, Dr. Suryani. We shall continue to the next question. All participants can start answering the question right now. Okay, thank you to the participants. I think this topic is brought by Dr. Sherini. Please to Dr. Sherini.
Yeah, so majority of the participants get the answer right. So women taking carbamazepine can breastfeed their baby because carbamazepine is not transferred to milk in significant amounts. And the risk of fetal malformation for valproate, it is high, but it's also dose dependent. So it's the higher you are on valproate, then the higher the dose of fetal malformation. And if the pregnant woman is pregnant and she's on valproate, then I think we have discussed this. Best is just to continue the valproate and better not do anything about it. And we shouldn't be stopping the anti-epileptic before they plan for pregnancy, unless you have discussed and all that. But generally you probably wouldn't want to stop that and continue controlling their seizures. And then women taking valproate for generalized seizures should be switched to carbamazepine. Number one, carbamazepine is not really the drug of choice for generalized seizure. And the drug of choice probably is lamotrigine, or if you want to change to levetiracetam. That's it.
Thank you very much, Dr. Sherini, for the explanation. I think we can continue to the next question. Here is the next question. All participants can start answering and do not forget to press submit. I think this question is on Professor Ernie's topic.
Yeah, that's fantastic. Very good. I don't have anything to say, I think. So yeah, there are lots of reasons. There are lots of reasons, unfortunately, for seizures to continue, including the dose is not high enough, patients not taking it regularly, the diagnosis is wrong, there may be progressive pathology. So all of those things are possible. So the last one is the correct answer, and 96%, that's fantastic. Thank you.
Thank you very much, Professor. I think we should continue on the next question. And here's the next question, please, to all participants. Thank you to the participants. I think this question is on status epilepticus by Professor Kwan.
Actually, I think, okay, the answers between the A and B maybe both looks right, but to me, maybe B is more correct, not the A. The first step in the management of status, I didn't mention today, but I think every doctor should keep in mind. That is the most important thing, is to keep ABC stable, to keep the airway, to keep the breathing, to keep the circulation stable, and then you consider the medication treatment. And of course, the first step is to control the seizure. Please remember, but if the seizure is not a generalized convulsive seizures, not a generalized convulsive status, instead it is just an absence status epilepticus or a focal seizure status epilepticus without impairment of consciousness, then the risk of the life is somewhat lower. So it is not necessary to give IV diazepam. At times, when we give IV diazepam, we will have some serious side effect, for example, sudden apnea or sudden collapse of the circulation. So it depends on the seizure type. So the answer B, the prognosis of status epilepticus depends on the cause. Yeah, I agree. The second one, the B, is more correct, because if you do not treat, for example, the status epilepticus is caused by, for example, by autoimmune encephalitis or viral encephalitis or a bacterial meningoencephalitis. If you do not treat these underlying diseases, you will have a higher mortality rate, although you have given the patient enough anti-seizure medications. So I think the answer B is more correct. And the answer C, the patient should not be treated until the seizure has been present at least 30 minutes. Remember, Trinka suggested to treat if this is a generalized convulsive status, you should treat at the time 1, that is 5 minutes. And the answer D, the patient who has 1 seizure every 10 minutes for an hour and does not recover fully between seizures is not in status. I think this is against the definition of status. Yeah, if the patient do not fully recover between seizures, it is still compatible with the diagnosis of status epilepticus. And the answer E, intramuscular diazepam is good alternative if IV diazepam is not possible. From pharmacodynamics and pharmacokinetics, intravascular diazepam is ineffective. Only diazepam must only be given by intravenous. Also, but if you give lorazepam or if you give midazolam, you can give intravenously or intramuscularly. So my answer is B. Thank you.
Thank you, Professor Kwan. I think we should continue on the next question. Okay, this is the next question to our participant. Please do answer and do not forget to press submit. Okay, thank you. I think this question is on Dr. Ahmad's topic.
Fantastic, absolutely right. True absence seizures are usually brief, they're rarely longer than 30 seconds, and they're very frequent, not once a month kind of thing, multiple daily. It can occur anytime. Lip smacking is acceptable, but it's not that wouldn't be the distinguishing feature. The distinguishing feature is still the duration of the seizures and the frequency. I'm glad that most people got it right. Thanks.
Thank you, Dr. Ahmad. Okay, we shall continue on the next question. Okay, this is the next question. To all participants, we can start answering and do not forget to press submit. Okay, thank you. I think this questions is on Professor John's EEG topic.
Very good. A single EEG routine will show epileptiform abnormality in between 25 and 50% of patients. So this is an overestimate, 80%. Second, very good. Most of you feel that doing sleep EEG increases the sensitivity, and this is definitely correct. The percentage perhaps goes up to about 80%. EEG is not helpful in choosing therapy. Well, we know that it is, not only acutely in status epilepticus, but if we see focal or generalized epileptiform abnormalities. Abnormal epileptiform abnormalities on EEG of normal people does happen, but it's quite rare. In adults, less than about 1 in 200 people might show incidental photoparoxysmal response or fragments of spike and wave, particularly if family history of epilepsy. In children, maybe 5% of children may have epileptiform abnormalities, not necessarily generalized spike wave, but centrotemporal spikes or photoparoxysmal responses as an incidental finding, particularly if there's a family history, but 10% is too much. An EEG in a normal person is normal. Repeat EEG is not helpful. Well, this is not the case. More EEG provides a greater sample and an opportunity to find abnormalities that have been missed, not to replace clinical assessment, but to enhance the evaluation. So well done.
Thank you, Professor John, on the explanation. I think we shall continue on the next question. This is the next question. Please, to all participants can answer and do not forget to press submit.
Is there a typo there? A and B are the same.
Sorry, Professor Raymond. I think there is, yes, indeed a typo. Thank you. I think this is Professor Tan's topic on cultural issues.
Well, because it's not very clear, the first two answers, the questions are not very clear, you know. She should not go to river alone. She may be just going to the river bank, you know, rather than she not go to swim in the river alone. Then I think that is correct. So the question is not very clear whether she should go to river with her friends. I mean, she should go to river to have a walk, riverside to have a walk, or she actually swimming. I think the rest of the questions are all I agree. So there, as what Prof. Raymond say, there may be some typo or something in the question, because you know, the correct answer hasn't come out, I think. Kenita, that's my response.
The majority is answering she should not go to the river alone, Professor Tan.
Yeah, you know, what a pity. River is so pretty, you know.
Okay, Professor Tan, thank you for the explanation. I think we should continue on the next question. Okay, this is the next question. Please, to all participants can answer the question and do not forget to press submit. Thank you. And I think this is Dr. Chen Chen's topic on neonatal and infantile seizures.
Yeah. I think the participants got good reply for the answer. Because maybe I have not enough time to explain it clearly. Because remember for neonatal seizures, the most common cause is hypoxic ischemia encephalopathy. It means acute symptomatic seizure. But for neonatal epilepsy, is relative not so frequent compared with acute symptomatic neonatal seizure. So we are maybe rather for my cases rather related to neonatal epilepsy. So I would like to talk about maybe structure, genetic, and metabolic etiology. But for this question, the most common cause of the neonatal seizure, right, is hypoxic ischemia encephalopathy, no doubt.
Thank you, Dr. Chen Chen, for explanation. And we should continue on the last question. Thank you very much. I think this topic can be either Dr. Suryani's or Dr. Ahmad's.
Maybe Dr. Suryani.
Is it mine? Okay, I will think that use for treating absence seizure. I think valproic acid is suitable. Not phenytoin, not phenobarbital, not diazepam, Dr. Yeah, I think valproic acid the most commonly used. Topiramate can also be used, but I think the most commonly used is valproic acid.
Dr. Suryani, does Dr. Ahmad has anything to add on this question?
Oh, no, thank you.
Okay, thank you very much. I think the post-test is finished. We will later compare about the answers on the pre-test and the post-test, but right now we should move on to the feedback session, which will be chaired by Dr. Herliani Kosama. To Dr. Herliani, all the time is yours.
Thank you. So this is the feedback from the participant for this event. Next slide. The majority of participants very suitable with the material and meet their expectation. Next slide. And strongly agree that the material applicable in their clinical practice. Next slide. And the tutor have a great understanding of the topic. Next slide. But for the time allocation, 26%, only 26% agreed with the allocation of time. But if we see, I think is enough. Next slide. And the tutor presenting the material is understandable and applicable manner. Next slide. The time allocation for discussion, only half of the participants agree. Next slide. And the tutor can guide and explain well. Next slide. And almost all the participants have difficulty in language. So there's a language barrier in this event. Only 41% is have no difficulty. So half of the participants have the language barrier problem. Next slide. Next slide. Okay, so the most frequent problem during the session is a language barrier, connection problem, and nervous or anxious in group session. Next slide. And they suggest to add another material for the next event about EEG, intractable status epilepsy, neonatal seizure, epilepsy catamenial, AED interaction and effect polytherapy, epilepsy at various comorbid, and epilepsy with COVID-19. Next slide. And they want to learn about treatment of seizure with loss of consciousness in remote area without EEG facilitation, legal issue in epileptic patient, drug-resistant epilepsy, and chronic medication that can induce epileptic discharge or status epilepticus. Thank you. Oh, sorry. For the suggestion and critique, some video are unclear. Hope co-host can translate to English. Discussion time was too short. Need longer duration for question and answer session, and extend the course times to 3 to 4 days. Thank you. For the pre-test and post-test, is it ready, the IT team?
Still more need time.
Okay, so while waiting for the comparison between pre and post-test, I want to say thank you to the ASEPA and team, and also for all the tutors, and also for the participant, and the residency program in center in Indonesia which participate to this event. Thank you for all your attention and your help. I believe that without you, this event will not be happen. Thank you and God bless you all.
Thank you very much, Dr. Heriani.
Thank you.
Yeah, thank you, Hariani. Thank you for your very nice organizing this activity. Thank you very much.
Thank you. Very successful activity.
Thank you, Dr. Heliani. Thank you all the tutors.
Thank you for all the tutors. Thank you for participating.
Yeah, thank you, everyone. Thank you, the organizing committee and all the participants and Dr. Heliani especially.
Thank you, everyone, for giving me this chance. And this has been a first time. Thank you, Lim, for encouraging me. Thank you, everybody.
Thank you.
Thank you. Thank you from far away, from Pakistan.
Yeah.
And thank you, Vinayam from India.
Yeah, thank you. Thank you.
The only problem was getting up early in the morning. on two, one national holiday and one Sunday holiday.
Yeah, it was our Independence Day, you know.
Yeah. So it's today for you.
Yeah, it was Independence Day for us, the Independence Day weekend.
Okay.
So,
yeah,
sorry.
please, Prof. Khan.
Before the, sorry to interrupt you. Do I have the honor to invite the president of Indonesian Epilepsy Society, the Professor Bintoro, to say something to us?
Sure, Prof. Dr. Aris, please.
Okay, thank you very much. Yeah. So first time on behalf of Epilepsy Group Indonesia and Eli Indonesian chapter, we would like to say thank you very much for this event. I think this is the first time.
Sama gitu pasien yang umum tidak dapat di pasien kalau tidak visiter memang itu perawat. Padahal
Kenita bisa tolong di unmute, di mute.
Ya, sudah dokter, maaf dok.
This is the first time of ASEPA to do the teaching course by virtual. Correct. And this is the first time. So maybe this is the new model for us from Indonesia to make other teaching course this model. But we have finished this event, and I already say that this is a good teaching course because all of the participants meet many cases here, and then they discuss with anything they know in Indonesia bahasa, and sometimes they could say in English well. So I think it's very good for us. And thank you for the committee, ASEPA, and then for the local Heliani for all of the successful this event.
Thank you, President.
I hope next time we do the other place in Indonesia.
Yeah, we should have more education courses in Indonesia. And Heliani, can I invite John Dan to say something?
Okay, you can.
Yeah, the incumbent, chairperson of the IREAO, John Dan, Professor John Dan, would you like to say something to all the participants?
Just very quickly, we all wish we can be together in the same place, but this is not to be at the moment. So we are together in a different way, and so whatever challenges, we will get over them as long as we work together as friends.
Thank you. Okay, I'll give it back to you, Heliani. Thank you again, Heliani. I mean, thank you.
Thank you, Prof.
Thank you very much.
Okay, so this is the result from the pre-test and post-test, the comparison. Slide, please.
Okay, doctor, the slide is showing now.
Okay, so for, I think we need to exclude number 9 because there's a typo there. Number 1 increase about 16%. Number 2 increase about 12%. Number 3 increase about 31%. Number 4 increase about 10%. Number 5, increase about 18%. Number 6, 11% increase. Number 7, 25% increase. Number 8, 17% increase. Number 9, 16% increase. Number 10, 21%, and number 11, 12%. So overall, the post-test is better than pre-test. Thank you.
Herliani,
Yeah.
number 4 is decrease.
Oh, sorry. Oh, yeah, decrease.
Whose question is it?
Number 4, topics.
4 is about women's issues, doctor.
Sorry?
Like carbamazepine, breastfeeding and stuff.
Okay.
Yeah, except for number 4. Sorry. Okay, I think we need to move to the next, the closing remarks from Prof. Ernie.
Yeah, thank you. It's been a pretty long weekend, hasn't it? It seems like it's a week ago that we started. It doesn't seem like it was just yesterday morning. So yeah, I just have to thank everybody as well. The presenters who prepared the cases and led the discussions, the tutors as well who gave up their time and also tried very hard to make everybody feel comfortable and contribute. The local organisers, it looks like there's a tremendous amount of work really in making this run smoothly. I can certainly see that, especially to Herliani and Kenita, but also all of the helpers in the groups, and I would imagine there's probably other people. And thank you to all of the participants for coming and for contributing and for wanting to basically to improve the care of the patients, which is really what it's all about. So thank you all for giving up your weekends to do that. I hope the participants did enjoy it in the end. And I'm sorry for I'm sorry for making some of you feel anxious and stressed. That's obviously not what we want to do, but we hope that things got better as it went on, and we hope you did enjoy it. We also obviously hope very much that this does help the care of your patients. It's not technology, it's not availability of new drugs that's going to make a difference. It's your clinical skills and how you talk to people and how you look after them. John, I think, has made that point very clearly. It's that's really the most important thing, and hopefully that's been improved by this weekend. Thank you also for the feedback, and we will certainly think about ways that we can improve things. I'm just very sorry that we can't be in Indonesia. Manado looks like a beautiful place on those pictures, and here we are sitting at home for the weekend. So maybe we can all get together sometime. It would be lovely to. I think it would be lovely to go to Manado. It looks like a nice place for a holiday, and there's obviously some lovely people there. So. Thank you all very much, everybody who has put so much work into this, and I do hope it has been it has been worth it for you. So I'll finish there. Thank you, and have a good rest of weekend, and everybody stay safe until life comes back to normal, if it ever does. Thank you.
Thank
Thank you,
you.
Ernie. Thank you.
Thank you, Ernie.
Ernie.
Thank you. Okay.
Thank you very much, Professor.
Thank you.
And to every panelists and every faculty members, all the speakers and tutors, and every participants that has been very loyal to stay until this evening. There's still more than 100 people staying in the room. And I think this wraps up the event of the virtual epilepsy summer school. And hopefully we can meet again sometime, maybe not virtually next time, hopefully. So I think we can close this event.
Kenesa?
Yes, Professor Kwan.
Maybe there are some tutors want to say something to us.
Oh, yes, please.
Are there? Yeah?
Yes, please, if there's any faculty members who would like to speak.
Yeah.
Say something.
Before saying goodbye. Dr. Chen Chen and Vinaya?
Yeah, so it was a very wonderful course, and I thank especially the local organizers, Lenny, and especially the Dr. Lim, who has taken all the trouble to do this course, and all the other participants. And I hope ASEPA will be able to replicate these courses in some other parts in the coming years, in the coming months. Thank you all. Thank you for a good session.
Thank you.
Yes, Sri Ari. So, Neurologi, are you still there? Decunia, are you still there? Chen Chen, do you want to say something? Raymond or Zhongding?
I'd like to thank everyone. I firstly thank the organizers for inviting me, and of course to the Heliani, who did a lot of work and so on, and all the tutors. Tutors are wonderful. All the talks were very clear. I think it was very educational, and I hope we can do this again. I think it's going to be online for a long time, these courses. Okay, thanks again.
Is there anyone want to say anything before saying goodbye?
No, I just want to appreciate the opportunity to have a chance to work with you. I learned much from you. Thank you.
It's my first time doing this as well, and I think I really enjoy it. And thank you for giving me the opportunity. So hopefully I can join again next time.
Thank you. Nice to meet you. Anyone more?
I think this is first time for everybody doing the virtual course in ASEPA. So I'm very happy that I can join this event. Thank you for the ASEPA and the organizing committee.
Thank you, Sriani. Anyone?
Okay, I would like to thank you also, Professor Kwan. It's my first time also, like Dr. Surani said, it's first time for all of us. Thank you for the knowledge and the discussion sharing. We really need your experience in treating people with epilepsy. Thank you very much. And also for the organizing committee, Dr. Herliani Kosama. Thank you.
Thank you for your help.
Smile, Dr. Herliani, smile, it's over.
Huge stress.
In fact, the point is that we are very stressed with Herlianis and the teams preparing this, and have so many sleepless nights. But thank you again to Herlianis and the team and the helpers as well.
Qin Xiang, thank you. 谢谢你. Without your help, this will never success. Okay, thank you very much.
Mainly Herlianis and her,
Yeah,
her girls and boys.
especially Herniani, the local organizer.
Yeah,
Hardworking.
yeah.
Thank you.
Actually, Prof. Lim helped me a lot. I always ask him a lot of questions. Thanks, Prof. Lim.
So who is next? Yeah, Tony Hamid.
Yeah, from me, it's I think it's amazing event, and thank you, because I'm sure this event is very, very helpful for Indonesian neurologists. Yes. Thank you.
Thank you for your help. So who is the next? Okay. Okay. If there is no one wants to say more, so Kanisa.
Thank you very much, Afwan. Thank you very much, everyone, especially the faculty members, which have been very high in spirit in teaching us, and all the participants, giving us a lot of knowledge, a lot of experience for us and for the clinical practice for all the neurologists. Thank you very much, and we appreciate this huge opportunity, and we hope that there will be more to come. And thank you very much. And I think this wraps up the event, and hopefully we can see each other again sometime, either virtual or maybe in other ways. Thank you very much.
Thank you, Kanisa.
Thank you, Doctor.
Thank you.
Thank you. Thank you.
Thank you. See you. See you.
Thank you, professors and doctors.
Bye.
Recording stopped.
Okay. Bye-bye.
Bye-bye.
Bye.
Bye.
Ernie, Prof.
Doctors and
Jonan, Prof.
professors.
Jonathan, Prof. Juan, Prof. Lee. Bye.